Welcome to Feedback Loop 1 for health professionals, and this is the first feedback loop for the co-design of the safe space in the Murrumbidgee LHD, specifically the Wagga one. As we know, it's a large region here, so there are actually Murrumbidgee LHD is getting 2 safe spaces, one in Griffiths and one in Wagga. Thanks, Tina. So Tina and I are facilitators with Roses in the Ocean, and we'll be presenting what's come out of the health professionals' conversations so far in this co-design process. So we'll begin with some acknowledgements. First of all, we'd like to acknowledge the original occupants and traditional custodians of all the lands we're meeting on today in a virtual environment. That's often a lot of different lands, but specifically to acknowledge the Wurundjeri people of this region that the safe space is going to be established on, and to pay our respects to their elders, past, present, and also to their emerging leaders, and also to acknowledge and pay our respects to any Aboriginal and Torres Strait Islander people who are participating in the co-design of a safe space in this region, and also just to acknowledge the enormous contributions that Indigenous communities make to suicide prevention efforts of all stripes throughout Australia. Thanks, Tina. In the context of suicide prevention, we also like to acknowledge people with a lived experience of suicide, and also to just really acknowledge and to pay our respects to the people that are contributing that real expertise, the uniquely valuable expertise that people who are experts by experience bring to co-design processes, particularly in relation to service improvement in the context of non-clinical services. Thanks, Tina. And just a high-level overview of the co-design process so far. So we've already spoken to people with lived experience in this region through focus group conversations. So these smaller group conversations, we then brought them together as a group. I think there's 9 of them to do a half-day online co-design session. So we really, through those 2 processes, explored what the feelings and emotions associated with trying to seek help through ED or supporting someone to do so, what that felt like, the reasons why they felt that way, also what were some of the unmet needs there if they did have negative experiences. And then we started to explore ways to meet those needs and what a safe space ideally would look like in this area, in this local area. We then have recently had a series of focus group conversations with health professionals, similarly to people with lived experience, bringing smaller groups of people together. And this webinar really is about communicating the outputs of those specific focus group conversations. And so this is feedback loop 1, and really is to provide that context to the process to make sure that we've captured everything that was shared in those initial sessions. So health professionals that are watching this webinar can have a look and check that their perspectives and insights are accurately captured. And also through this feedback process, encouraging people that haven't been directly involved in the co-design session so far to really participate, particularly in the survey, so we can gather much broader views and experiences. We know that it's super important to get as broad and diverse range of perspectives from community members as possible if the local safe space is to really meet those diverse needs and wants of community members locally. And then also that will just help us to prepare for the next stage of co-design. We'll be feeding all of that information back in, and that will be turned around and then presented at the next session, which is the health professionals combined session. Thanks, Tina. So we know, as I've just said, that it's important to get a diverse range of perspectives in the room in co-design if you really want to get a really robust model that is more likely to meet the needs of people in the local area. But in relation to suicide prevention services, particularly these kind of innovative services, we know it's important to get people on the ground that have experience of working in these systems or supporting people to access these services like ED in hospital. And so in the context of this local area, we have had, that has included a manager from Headspace, for example, the coordinator of consumer participation, in the LHD, also police inspector, and someone from the NGO sector. So you can see we really are getting quite a diverse range of perspectives from service providers from different sectors and different health professionals and social services staff as well. Thanks, Tina. So in terms of what we asked health professionals to share with us, we really wanted to find out what it's like to walk a day in the shoes of a health professional, doing their very best to provide care to people in suicidal crisis within what we know is a very complex and sometimes very difficult system, not just for the consumers of the system, but also for the people that are trying to provide great support for people. So we walk through the experience of being a health professional through the process of finding and accessing support, specifically through the emergency department, what the feelings were like associated with that, and the reasons why those people felt that way. And we did that through the various touch points of accessing help for people in suicidal crisis. So finding those points of when people are reaching out to find help, arriving at initial assessment when someone comes into the ED, the waiting period, then the actual treatment. Now that could be in ED, but it could also be in an inpatient setting, and then leaving. And while we appreciate that those different perspectives we were talking about, not all health professionals would have experience of supporting people at each of these touch points. It was important to get people to just to talk about what experience they do have. So some health professionals or other professionals will only have experience in supporting people to find help through ED, for example. So all of those perspectives are equally important. And then after that, we then spent some time talking to health professionals about what would they need to feel confident and comfortable to support a safe space in their region, to support someone or recommend to someone that they could access a safe space in suicidal crisis. So the following slides highlight the key points of discussion here, and it's really about the fact that we've collated that information. Beacon Strategies does that and has started to identify some of the common themes that are emerging from speaking with health professionals. So Tina, who co-facilitated those conversations, is going to now just walk you through that discussion. Thanks, Tina.
Thanks, Carrie. So the people who spoke to us who were health professionals, what we asked them was what it was like for them to support someone or be with someone as they go through that process of accessing help during a suicidal crisis and accessing it through the emergency department. And the conversation was really about the health professionals helping us to understand their experience. So we asked them, what's it like to walk in your shoes in that process that a lot of people go through when they're in a suicidal crisis? And one of the great things about the group that spoke to us, we had 3 small groups from Wagga, and all of the information from those groups has been brought together in these slides. And it just represented a great range of perspectives from people who are actually working in the emergency department to people who maybe or outside the public system, but were either supporting people to get in contact with the emergency department and to access help that way, or were supporting them as they went through that process of getting help through the emergency department. So the first thing we asked health professionals about was what it is like for them when they're either helping someone to find assistance through the emergency department or supporting them to sort of find that help. And there are a number of feelings that came up for the health professionals, and you can see them on the left here. So a big word that was coming up quite a bit was the idea that health professionals felt frustrated. Some felt quite cross. A lot felt unsure when they were encouraging somebody to access help through the emergency department, or they felt uncomfortable. One person said that they had really mixed feelings around that experience. But some people spoke about having strong empathy for the person that they were supporting, or feeling a sense of responsibility for that person. And along with that sense of responsibility was that feeling of duty, which one person said that those responsibilities are actually quite nerve-wracking for health professionals. So we asked health professionals, what else can you tell us about this experience for a health professional supporting somebody to find assistance through the emergency department? And it was interesting because some of the health professionals that we spoke to, their role was entirely about assisting people and encouraging people to contact the emergency department. And the health professionals said that they feel uncertainty about what happens once the person gets to the emergency department. There was a comment that a lot of organisations do their own assessments before somebody is encouraged to go to the emergency department. And there was a feeling that those assessments are sometimes ignored. Another person said that their role really was to make a very quick assessment of a person's needs. And the priority is to minimise harm. And then it's about handing over and calling an ambulance if needed. Sometimes health professionals suggest other services other than the emergency department. And sometimes they take people directly to the emergency department themselves or assist the person to go to the emergency department via ambulance. But the comment was made that ambulances sometimes can't get there quick enough. Some health professionals feel responsible for educating and advocating for consumers who are seeking help through the emergency department. And the comment was made that people might actually go through several emergency department admissions. Sometimes the situation is quite tense for health professionals and they feel they need to prepare for almost a conflict situation. And they also feel very responsible for making an assessment of the need for medical help. So there were some specific comments that we thought we'd feed back to people. So these are all quotes from the conversations that we had with health professionals about that experience of assisting a person to find help through the emergency department. So one health professional said, I don't know how to give them the correct information to have faith in the system. Another person commented that thinking about this makes me realise how hard this all is. Another person said, we're there to do a job and we're often in a clinical mindset. Another person told us that they usually put people in touch with a health service which escalates to the emergency department. And one person expressed concern that not everyone finds their way there. So that was a comment in that it can be quite stressful for health professionals when they're encouraging someone to go to the emergency department and they have no way of knowing whether that's something that has actually happened. So then we asked health professionals about what it's like for them if they're with a person when they arrive at the emergency department and during that initial assessment of the person. And some of the people we spoke to were supporting someone who was in that stage of the process. And some of the people we spoke to were actually involved in that initial assessment when a person arrives. And the words that came up during that conversation to describe what it feels like for health professionals were impotent, frustrated, they feel angry, a lot of them feel concerned, feel bad for the person who is being assessed, and feel quite uncertain about what's happening. But I also need to point out that some people actually feel quite comfortable and that they have faith in that process of initial assessment. And so it's really, there's some mixed feelings. So when we asked health professionals to provide us a little bit more information about what it's like for them during arrival at the emergency department and the initial assessment of a person who's in a suicidal crisis. They gave us some really useful information about that experience. So they told us that there's often inadequate assessment space and that really what is needed is a quiet and private space for people to be in. They also commented that people need a quicker triage and a faster process, even if they're not in acute danger, because that long process causes frustration. And they were concerned that a lot of people leave before that process is complete. They also told us that patients' experiences vary greatly depending on how busy the emergency department is, and that the experience can be quite disempowering for people who are supporting the person. So they felt this can be disempowering for family, but they also felt that the process of supporting someone as a health professional through that arrival and initial assessment can be quite disempowering. And they commented that prioritization in the emergency department shows a lack of concern for people and that it causes people to lose faith in the system and to feel dismissed. One person who we spoke to, this health professional, told us there's lots going through your mind during this arrival and an initial assessment that you're not even sure if the person will get the help they need, and that your priority is to try and keep the situation calm, but it's not a good environment for doing that. We were also told that at times there's insufficient security staff to take over from police. And so there was a lot of concern and stress associated with that. And one person also commented that they felt healthcare workers are very desensitized to these stories. So just a few specific quotes from the conversations around that arrival and initial assessment of people who are in a suicidal crisis. One worker commented, "Suicidal thoughts aren't always taken as seriously as they should be." Another health professional said, "Your skills as a professional can be questioned in front of the consumer." Another person said that for someone who hasn't been before, it's a really scary process. And we were also told that as a health professional, this person found himself apologising a lot. Sorry. Another health professional said that the process makes the person relive the experience. And that process of asking people for their story can be extremely distressing for them. We were also told that it can be frustrating in terms of prioritization, because mental health doesn't generate the same priority as maybe what other people approach the emergency department for help with. Another health professional said that they felt like they were banging their head against the door before you even get there, and that the whole process feels rushed. Some people get turned away, but then there are additional attempts. So then we asked our health professional groups if they could tell us about what it's like for them when they're either supporting or in some way treating a person who's in a suicidal crisis and they're waiting. So there can be many stages during a trip to the emergency department during a suicidal crisis when a person is waiting for long periods of time. And we asked health professionals, what's that like for you? And we were told that health professionals feel frustrated. They feel really bad about the person waiting. They feel awful, feel guilt, and feel very sad. So when we asked health professionals, what else can you tell us about this experience for you during the period when people are waiting? And they said wait times are much too long. We were told that sometimes wait times can be longer if a support worker is with the person. So there was a real feeling that sometimes a person's process through the emergency department is actually delayed by a support worker being with them, because the person is seen as being safe because they've got a worker there. And the workers who are involved in that can feel very frustrated and also really bad for the person who is having to wait longer periods of time. They also said that for a lot of workers, when they're supporting a person who's waiting in an emergency department, they feel like their role shifts from being a professional to being a babysitter. We were also told that the emergency department and inpatients, that they're working within rigid frameworks that don't always elicit the important information from the patient. So the worker, health professional, may feel like they have really valuable information and that the process isn't actually bringing that information out. And we were also told that health professionals really wish that someone could see someone straight away as soon as they arrive at emergency department seeking help. So these are just some quotes, some direct quotes from health professionals about that experience of supporting someone who's waiting in the emergency department. So we were told a person will be assessed as okay just because they're with a professional. Another person said, support workers are frustrated over prioritisation where the patient drops to the bottom of the ladder. Another health professional told us, action doesn't match the seriousness of the situation. Another health professional said, that there are some good, but overall, as a support worker, it's a disastrous situation. And another person told that it's not the most appropriate or the best place they could be. Alternate spaces might be better, for example, the GP, but they might not end up there. So then we asked health professionals about what it's like for them when a person is receiving treatment after approaching the emergency department for help during a suicidal crisis. There were really mixed feelings that came up during those discussions. So some people really felt it was an unfair situation when people were being treated or felt frustrated. Some felt concerned, but others said that it's good and a bit bad. And some health professionals expressed a feeling of relief once a person is definitely getting treatment. We asked them if they could tell us anything more about this experience when a person is receiving treatment. And what we were told was that health professionals are not always aware of what happens to people during treatment, and that it's really not a good feeling to not know how that person is. We were also told that sometimes a health professional feels really glad that the person has been prioritised, and that's a good outcome, and that something needs to happen for that healing process to occur. Another person commented that the emergency department does not always provide treatment, that sometimes it's just a cursory assessment. There was also a comment that when people are receiving treatment, that referrals don't always happen, and that sometimes there's a misunderstanding about other support services and what they offer. So some health professionals were concerned that people who were receiving treatment were actually being referred to inappropriate services for their needs. There were comments about unfair treatment and that people don't always get what they need. And there was also recognition that treatment is not great if people are there involuntarily. So some specific comments about the experience of health professionals when a person is receiving treatment. One person said, there's a misunderstanding of support services. People are referred to Headspace for things they can't help with. Another person said, everyone who presents should support and follow up. So that was a comment on the fact that not everybody does receive treatment. Another person commented that sometimes only a cursory assessment occurs in the emergency department rather than crisis. And another person commented that there's no communication about the patient during this time. So a lot of health professionals feel, I guess, cut out of the communication loop when a person is receiving treatment. So then we asked the health professional focus groups what it's like for them when a person gets to the end of this process and is leaving. So they might be leaving directly from the emergency department, they might be going home, or they might be leaving after being in a mental health unit and receiving treatment. And the feelings that people talked about here were also quite mixed. So some people feel quite happy when somebody is leaving and not too bad. Some people feel really comfortable with the fact that the person is leaving. But there were other people who expressed that sometimes they're concerned and worried for the person at that time, or that they might feel a sense of frustration when the person is leaving. And when we asked health professionals to let us know what this experience is about, what it's like for them when the person is leaving, we were told that people are usually going into safe care, but sometimes they're left in the care of an inappropriate person. So what they were specifically talking about there was organisations were sometimes quite aware that there were unsafe situations in people's homes, such as domestic violence, but that this hadn't been either detected or acknowledged during treatment or during the emergency department assessment, and that people were then sent home into what were actually quite dangerous situations for them. Also, we were told that sometimes people are discharged with inadequate follow-up. So we were told about people being leaving the emergency department and not the correct contact information hadn't actually been collected from the person, which meant that they couldn't have follow-up, or they might be referred to services and the services are not informed that they're coming, not informed about the referral. And like one person in particular spoke about how they'd support someone to access help through the emergency department. They wouldn't know what happened in that process. And the next thing that person would be arriving back on their doorstep, really in quite dire need of assistance. And that it had all come with the service being quite unaware of what had happened. Also, we were told by health professionals that usually there was a good assessment and discharge plan, and that the person was deemed well enough to leave, and that was good if they had the information that they needed to prevent a reoccurrence. But there was acknowledgement that people sometimes fall through the cracks and that repeat trips to the emergency department can be really frustrating, and that many people do find themselves back at the emergency department again in a suicidal crisis. Another person told us that when somebody leaves after approaching the emergency department, they just hope they're okay and they hope that the systems are okay. So a few specific comments that were made during these conversations about when people leave after approaching the emergency department or after treatment. One person said, they asked a question, how can people deem to be safe after such a short period? Another person said, sometimes not everything is picked up by staff. Another health professional commented that they can't confirm that a consumer won't be back at 9 a.m. in the next morning. One health professional observed that too much pressure is put on family and friends to take responsibility. And also another person sharing with us that they're not always aware of what happens to people next. So just a few general feelings and general comments that people were making in these health professional focus groups. The overall feelings were the biggest feeling that came out and that was repeated by many, many people at many stages of the process in these focus groups was that feeling of frustration. It was the most common word that was used during the conversations. Another person really said, I'm not happy or proud about what's happening in this process. And health professionals reported feeling quite powerless. Some general feedback or comments that were made. It was observed that local services do great work, but the system can be frustrating to navigate, and that the emergency department is not a good space for mental health, that it's noisy and busy and that people are being watched. Another person said, when reading case reports, it's apparent there are gaps and breakdown of process, and that the situation is not always taken as seriously as it should be. It was observed that it's not unheard for people to disengage with ongoing support, and also that they have to do a lot of running around to find out information. And health professionals were really clear that they want to provide better services. So just a few general quotes about that experience for health professionals. One person said, I don't feel like we provide the best services we could. Another person said, I can sum up the process in one word, frustrating. Another person said, it's hard to support people when the system isn't effective. Another health professional said, it's hard to know how to support healthcare workers. And another person shared with us, it's an emotional situation and we don't hear anything back. So then we had a chat with people and we said, if we're setting up these genuine alternatives to accessing help through an emergency department, and we're setting up these safe spaces, what do you need as health professionals to feel comfortable supporting someone to access help through one of these safe spaces? And there are a lot of ideas that were shared here. So some of the things that came up during that conversation were that it needs to be a space with kind, compassionate, empathetic people, and that it needs to have non-clinical staff with adequate mental health knowledge or training who can sit and listen. It was commented that for health professionals to feel comfortable helping people to access the safe space, they need to know there was an adequate level of staffing and that it was a welcoming, calm space, similar to a home with nice furniture. They want the ability for people just to sit as long as they need to. And that also needs to be a safe, secure space where people aren't exposed to further harm. So there was a lot of conversation around the fact that health professionals feel that we need to be making sure that we need to look at security as an issue in these safe spaces, because they're definitely not going to support someone to go somewhere where they feel that they might actually be at risk from other people. There was also talk about having a separate space for people who had heightened agitation, and that maybe that would increase that sense of safety. And the need for the safe space to collaborate with other services and for there to be adequate referrals and follow-up. Some health professionals would feel more comfortable helping people to access a safe space if there's support for diverse needs, ages, and backgrounds within the space. They'd like it to be in close proximity to the emergency department in case any situations arise where a person accessing the safe space needs to get in contact with the emergency department. They would like to see staff with lived experience that will make health professionals feel comfortable. And they would like those peer workers to be able to escalate or de-escalate the situations. And they really want to see the peer workers getting the training that they need to be able to do that. They'd also like them to get the training they need to be able to deal with other complications that might come up in the safe spaces, with clarity around their non-clinical role. And they would actually, this was something there was a lot of conversation around. Health professionals they would feel more comfortable supporting people to access a safe space if they have a clearer understanding of what's meant by it being a non-clinical space and what role clinical support might provide for people who have accessed the safe space. They spoke about needing to trust the safe space and having a better understanding of its out of hours role. And also they spoke about the need for an option of non-referral and a point to services that don't have long logistical requirements. So that was about people getting help when they actually need help and when they approach the safe space for support. Another comment on security, that need for health professionals really would like some assurance around that level of security, but they don't want to see security guards in the safe space. So feel more comfortable supporting people to access the space if there's a plan for those who roam and attempt to use the services. So that's vague language, but specifically what that meant, there was a concern that the safe space might become a place where homeless people seek shelter. And some of the health professionals said that they would feel more confident supporting people in distress and in a suicidal crisis to access the safe space if there was some kind of plan for what they're going to do to make sure that it remains a space for people in suicidal crisis.
Thanks, Tina. You can see, well, two things. One, just what incredibly important information that was gathered through those focused conversations with health professionals. Really, really important experiences and insights that are brought to those conversations. But also, from our perspective, we can really see how there are some common themes between health professionals and people with lived experience emerging, particularly around what a safe space, the needs that a safe space needs to meet that perhaps aren't being met through ED and hospital for people in suicidal crisis. So it's great to see those points of alignment starting to come together already. And so now we're happy to take people's questions. Anyone that's participating in this live, we'll give you a few minutes while people are just thinking through that. Perhaps we can just have a look at next steps and then we'll go back to this survey. If you could just show me, Tina, the next slide. So the next step, so this is the feedback loop one. So we've had the webinar that's also recorded for people to have a look at. We then get you to complete a survey. So people that have directly experienced, participated in the co-design process so far, we're getting you to give us input about whether your perspectives have been accurately captured and reflected in this presentation. We're also really wanting to encourage broader community input and involvement in this process. Obviously, only a few people can directly participate, particularly in an online co-design. So we're really looking for you to really spread the word about this survey and the webinar, get people that you know, sort of formal and informal networks of health professionals in your service or in your area to give us their views and perspectives on the co-design outputs so far. And then we'll have this health professional session 2, where health professionals will be provided with all of the lived experience outputs that were generated from their focused conversations and their session. And that is, I believe, on Tuesday, the 10th of November, that session. We'll then have another feedback loop, which is the same process, just really sort of communicating the outputs as they're coming, feeding them back, getting broader community input, also really getting that sense check from the people participating that we're accurately capturing what's said in the room. And then we have this final, what's called the joint stakeholder session, what I often call just the combined session. You're bringing people with lived experience and health professionals together. That's when you start to get really concrete about the details of the safe space in your area, what it's going to look like in practice when it's implemented on the ground, to try and sort of address maybe potential barriers to implementation and to work through those things to make sure that the safe space aligns with the ministry requirements of it, and then we'll have a final feedback loop, which is the same process, a live webinar, which is really to communicate the final outputs of the co-design. We still offer a final survey so we can get that final bit of consultation and input. And then Beacon Strategies, who Roses in the Ocean has partnered with, will turn all of that over and create a service specification document that gets handed to the LHD. And that is really the blueprint, the draft blueprint for the safe space in your region. So I don't see that there are any, if you could just take me back to the slide before, thanks Tina. There are no questions now. Of course, in this survey, so there'll be a link to it on the landing page of your LHD on the Roses website, there's the link. We really encourage you to complete it, and as I said, spread the word around it. It's super important to get everyone's perspectives here all throughout the process. And we really appreciate all of the contributions of health professionals in this region, and we know how important it is that health professionals, particularly on the ground, that are providing this support to people in suicidal crisis, that are doing their best to provide care, that we hear from all of you, so that this safe space is one that's going to work for everyone in the community. So thank you very much for your time and your contributions, and we look forward to seeing you on the 10th.
Thank you.